This is Chapter 10 of Wilkins, Personal, Dental, and Medical Histories. But before we delve into this chapter, just want to review a little bit about this ADPI we've been talking about. And assessment is one of the first things that we as dental hygiene professionals do. An assessment in dental hygiene practice is the collection of pertinent facts, clinical data, and dental materials such as radiographs and study models related to the patient's oral health and overall health status. So the initial assessment data is used in our planning care, and it acts as a guide during all of our treatment. After care has been provided, we recollect the assessment data and use that to evaluate the outcomes of the dental hygiene intervention. Did it work? Didn't it work? And if it didn't work, why not? So an efficiently conducted assessment and critical analysis of assessment findings include having a permanent, continuing, accurate, and complete record of the patient's oral health as well as general health. It helps formulate the dental hygiene diagnostic statements from which the patient-oriented dental hygiene care plan can be prepared. It guides instrumentation during the dental hygiene treatment, as well as provides a basis to correlate dental hygiene care with the comprehensive dental treatment plan. Now, the dental hygiene process of care, the assessment is the first step in this process of care. And if you look on Figure 4.1, that will, again, give you the ADPI. It's critical analysis of the data that identifies the patient problems used to formulate the dental hygiene diagnosis as well as develop an individualized care plan. So a comprehensive and accurate assessment data aids the dental hygienist, which is you, in identifying health-related factors that affect the management of dental hygiene care, as well as risk factors for oral and/or systemic disease. Gives a description of personal and culturally related habits that affect the oral status, as well as health-related attitudes of the patient and the value placed on maintenance of oral health and the prevention of disease. It also gives oral hygiene methods and communication strategies that will meet that patient's individual needs. So built into the sequence of the clinical procedures is the initiation of steps for arresting oral disease processes, as well as controlling etiological or causative factors and prevent episodes of recurrence of oral disease. Now, for ethical applications and ethical theory, often based on norms or rules that ask which type of action is morally correct, offers a general approach to an ethical problem. So a dental professional may consider the most favorable outcome of a particular situation, what guidelines to follow, and whether to rely on personal and professional virtues when making a judgment. So a few of the many philosophical theories that apply to the delivery of dental care with corresponding definitions are in the textbook on Table 4.1. So we have some ethical theories that include deontology, rights theory, teleology, utilitarianism, as well as virtue ethics. So review those in the textbook. And now we can actually get on to Chapter 10. We're going to talk about history preparation, the questionnaire, the interview, the items included in the history, the immediate applications of patient histories, pre-treatment necessary for antibiotic prophylaxis. The learning outcomes are also listed in the textbook. And we can continue on. So for safe, evidence-based dental and dental hygiene care, a thorough patient health history is an essential part of the complete assessment. The keywords relating to the preparation and use of the histories are defined on box 10.1. You need to review those. A history directs and guides the steps to be taken in preparation for, during, and following appointments. Some important points about the patient history are going to be discussed here. So the history is needed before oral examination procedures with periodontal probes and explorers are carried out. The use of instruments that would manipulate soft tissues around the teeth is contraindicated until after it's been determined whether antibiotic premedication is required or some alteration of other medications. For example, if the patient's on a blood thinner, their physician might want them to be weaned off a few days prior to tissue manipulation and then be put back on their full dose after their hygiene services or dental services are done. But when a question exists about the medical history as described by the patient, or when an unusual or abnormal condition is observed, consultation with the patient's primary care provider or referral for examination of the patient who doesn't have a primary care provider is required. We have medical consult forms in the clinic. So when we need an okay from a physician, can we proceed with these services for our patient, there is a form that we fill out that we give to the patient that has to be signed by the doctor that says we can proceed, or if we can't proceed or can proceed with these precautions. So even emergency treatment needs to be postponed or kept to a minimum until the patient's medical status is determined. The significance of taking a complete and accurate patient history can't be overemphasized, okay, because oral conditions reflect the general health of the patient. Dental procedures may complicate or be complicated by existing pathologic or physiological conditions elsewhere in the body. General health factors influence response to treatment, such as tissue healing, so that can influence the outcomes that you might be expecting. And the state of the patient's health is constantly changing, so the history has to be updated continually. Carefully prepared personal, medical, and dental histories are used in comprehensive patient care to provide information pertinent to the etiology and diagnosis of oral conditions and the total patient care plan. These histories also reveal conditions that might necessitate precautions, modifications, or adaptations during appointments to make sure that dental and dental hygiene procedures aren't going to harm the patient and prevent emergency situations. The history can also aid in the identification of possible unrecognized conditions that the patient will be referred out for further diagnosis and treatment. They can permit appraisal of the general health and nutritional status, which in turn contributes to the prognosis of success of the patient care plan as well as instruction. Histories can also give insight into emotional and psychological factors, attitudes, prejudices that might affect present appointments as well as continuing care. And it also documents records for reference and comparison over a series of appointments for periodic follow-ups. The history also furnishes evidence in legal matters if questions arise. These histories can identify cultural beliefs and practices that may affect risk for oral disease, as well as determine ethnic and racial influences that might have risk factors for oral diseases. So one of the first things is to, when we have the patient come back, we're going to introduce ourselves to the patient. And this is a way, when we're doing the interview for the patient, to allow us to get to know the patient better. We're educating the patient on why we're asking these questions. We're conveying a relationship of oral health as well as general health. And most importantly, we are building a rapport with the patient or the parent of the patient. Some of the limitations of the history. It is a subjective form. So inaccuracy or incompleteness might be missing. There is also limitations in the method of obtaining information. So are you giving the medical history to the patient to fill out on their own, and then they bring it back? Are you following up with adequate questions? There might be a language barrier also. They don't understand what we're asking. If we're asking medical questions, there might be a language barrier from English as a second language. They might not even be speaking English. And one of the nice things about our MetLife system is that the MetLife website has the medical history in 20-some-odd languages. So if you know the language that your patient speaks before they come in, you can email them the medical history. They can have it filled out in the comfort of their home. Then they can bring that in with them. And question number 16, question number 62 on their medical history in their language is the identical question number 16 and question number 62 on the English form, and the Spanish form, and the Urdu form, and the Farsi form. So there's great advantages to that. And there are different types of questions for the questionnaire. The system-oriented, the disease-oriented, the symptom-oriented, as well as the culture-oriented questionnaires. And they are pretty much self-explanatory. So a question is, are you thirsty much of the time? That's an example of which type of question for a health questionnaire. A system, a disease, a symptom, or a culture. All right. And now the are you thirsty much of the time is usually in a group of questions that are for the diabetes section. Are you thirsty much of the time? Do you urinate more than so many times a day? Have you lost weight recently? So that is a disease-oriented or a system-oriented type of history. The advantages of a questionnaire is that it can be very broad in scope, it can be time-saving, and they're consistent from one person to the next. So as you get to know the information that we're trying to get on a medical history, it's going to take you less and less time to interview the patient. And the patient may disclose more information than what's on the health form itself as you develop a dialogue. But it is a legal document, and we do require a patient's signature. The disadvantages of a pre-appointment or a self-history is that it is impersonal, it is inflexible, and we have to have follow-up questions. And that's the big thing. We don't just give a medical history to somebody and not have follow-up questions. So we do a combination, and it's an interview that we do. The participants are usually the patient and the clinician. The setting should be a relaxed setting. Oftentimes it's in the dental operatory. And we have to remember that we have an open bay system in both of our clinics. So we need to be sure that we're modulating our voice as much as possible so that the patient feels comfortable to disclose personal information without everybody hearing about it. So we need to modulate our voice. We can be going through the form and saying, oh, I see that you circled yes for number 32. And if number 32 might be an embarrassing or personal question, that is enough for the patient to, do you mind expanding on that? Were you treated? If so, what year? For example, if they had an STI, a sexually transmitted infection, they'll circle yes. Well, we don't want to, we don't need all the details, but it is nice to know what and when and was it treated. Because some of them, like genital herpes, especially if it's in the mouth, can spread, and it's not just a one-time deal. So the interview is something that you're going to get very comfortable with. It gives you personal contacts and develop rapport for the patient, and there's some flexibility in being able to discuss things. Some of the disadvantages are that it can be quite time-consuming. There could be some omission of items of importance because the patient just forgets about it or we've skipped over something. And there could be some patient embarrassment questions that they really are uncomfortable talking about. So they will skim over that. Items included in all the histories is information directly related to the patient care. There's usually demographic information. The age group would influence material selected for the care of the patient. For example, if you have somebody who's 95 with dementia, that is going to alter your care versus somebody who's 35 and fully functioning. And manifestations of systemic disease and medications can also influence your care decisions, and that all is included in the data. So there's always a personal history section of the medical history. And that data helps collect in for the planning care. It gives you the informed consent the patient signs. It lets you know if a physician is needed to be contacted, who their physician is, and sometimes there's culturally appropriate communication that might need to be determined as well. And up here in Northern Virginia, we have a lot of diversity. So a lot of times husbands are coming back speaking for the wives. We've got interpreters coming in, family members, friends, those type of things as well, that we have to be cognizant of, that other people are commenting on behalf of the patient. So for the dental history, we always start out with, is there a chief complaint? What brings you here? For dental hygiene, a lot of times is I want my teeth cleaned. Sometimes the front office will book an appointment with the hygienist because there's an opening. The patient calls, they have some sensitivity. You need a cleaning, so let's get you in with a hygienist. So there's always chief complaint. It's always nice for if you don't have a template and you're working on a paper chart or you're just free-forming your clinical notes, medical history reviewed, patient state, blah, blah, blah. Then you take your vital signs, blood pressure, pulse, respiration. Then you go into chief complaints, CC, chief complaints, or C-O, complaints of, is what you'll typically see. CC, for chief complaint, you can put a 0 with a line over it. They don't have one, okay? Sometimes they don't. But you want to also, for their dental history, find out about their previous as well as dental and preventive care. Are they ones that are seeking regular care, and if there's a problem with their mouth, they have it taken care of, or are they very sporadic in that? And sometimes that can tell you about the patient's attitude towards oral health. Where do they place it on the importance level for them? It might also delve into some of the patient's current health beliefs. Where is oral health as well as systemic health on their priority list? It can give you also a glimpse over their finances. They might want to get things done and taken care of, but they just don't have the means to do it. There's also questions on their personal daily care, which again is getting very close to what patients can be embarrassed about. So the medical history helps denote conditions that can complicate dental care. It can give rise to diseases requiring special precautions or pre-medication, like blood thinners. And it can also give rise to conditions requiring medicating drugs that the patient's taking that could influence the care or even contraindicate care. Okay, review question. Which type of patient would require antibiotic coverage during treatment? A patient with antihypertensive drugs, blood pressure, a patient with a latex allergy, a patient of Native American descent, or a patient at risk for infective endocarditis. Now, you don't even need to know what infective endocarditis is, but you know the cardiac is the heart, infective. Okay, there's something going on with the heart, so that would be the logical question, or the logical answer for this particular question. So part of the medical history, we're looking at gender, ethnic racial influences. Some diseases are more prevalent in certain races, in women versus men. So again, we're trying to get that information off the medical history. Allergies or untoward reactions to food, medications, local anesthetics, diseases or drugs with oral manifestations, communicable diseases, have they been treated, as well as physiological status of the patient. I have some hiccups. All right, so the immediate application of the history will influence our care plan as well as the evaluation before clinical assessments are done, and it's essential for the preparation of the care plan. Now, there's something called the human needs model that we're going to be going into as well, and the human needs is done after you do a medical history. For example, if the patient smokes, then they declare it on the medical history, and then there's another form called the human needs that's been developed, kind of like Maslow's hierarchy of needs. But smoking then would be addressed, and you'd have your dental hygiene intervention, which would be a smoking cessation plan suggested to the patient to see if they're ready for help with quitting to smoke. For medical consultations, it can be by phone for that day. We want written requests at the clinics, as well as referrals to other doctors are done as a written referral, and they are scanned into the chart if it's a paper. We have paper that we scan. But if there's a question that needs a medical consultation and the patient is scheduled for all day, for example, you don't want to dismiss them and say, here, go to the doctor. Sometimes you can call the patient's physician with their permission to try and get a verbal okay. You can also fax medical clearances. X-rays, radiation. Have they had radiation therapy recently? If so, where in the body? That may require a physician consultation. What is the status of those tissues? Can you manipulate them? Because after radiation, especially in the head and neck area, those tissues are very fragile and they might not respond to the manipulation of scaling and root planing. If you need radiographs, we need to explain the rationale for radiographs, and oftentimes we need to get an okay to make sure that what we are doing is not putting them at over the recommended allowance for radiographs. And there's something called prophylactic premedication. And those are mainly for patients that are at risk for infective endocarditis. Now, we do have patients that need to be premedicated with an antibiotic before we can manipulate the tissues and create any bleeding. That list of patients seems to be getting less and less each year. Every couple of years, the American Heart Association revises who they are recommending needing prophylactic premedication, so they're getting much more conservative. But the patients who need premedication are those that are at risk for infective endocarditis. Risk factors with invasive procedures, it's not just cleaning the teeth. It could be root canal, injections, placing a rubber dam clamp. All of those for typical patients who need pre-medication don't need it, but you just don't know how much manipulation is going to be too much for that particular patient. But there are guidelines for that. The routine use of antibiotics really isn't indicated for a lot of the patients 10, 15, 20 years ago that were receiving antibiotics. So we need to make sure that the patient that does require pre-medication has taken the medication at the appropriate time and at the recommended dose of antibiotics. I used to say, did you take your pre-med today? And the patient would say yes. Well, it wasn't until further investigation and discussion with the patient that I realized that they only had 2 pills left, so they took one the day before, and they were going to take one, it was just a mess. Now we ask, did you take your pre-medication? Yes. What did you take? Amoxicillin. How much? 4 of them, and when? If it's a 10 o'clock appointment, they should have taken it about 9 o'clock. So it's how much, what, how much, and when. And you document that the patient states they took 4 amoxicillin at 500 milligrams each, so that's 2,000 milligrams, at 9 o'clock for their 10 o'clock appointment. So you are just revisiting what they told you. Patients that are allergic for certain medications will be given something else. There are still physicians who have patients on different routines. So the American Heart Association does have guidelines, and in 2007 was the latest changes, I believe. And again, it is they get more and more conservative as they go along. The principles of pretreatment antibiotic therapy. The American Heart Association really has made recommendations for prevention of infective endocarditis for many, many years. And the first document was published in 1955 about this. And there have been 9 revisions since then. The latest one was in 2007, and I believe it was updated on the website in 2014. And former guidelines were based more on expert opinion or individual case studies than in 2007. And 2014, there was a review to attempt to be more evidence-based. So again, we're getting more and more conservative with what the recommendations are. But frequent exposure to random bacteremias, that's breathing in the mouth, resulting from daily activities that the patient does, brushing and flossing, nicking their mouth with a Dorito or something, are more likely to cause a bacteremia and infective carditis than treatment procedures performed in the dental office. So antibiotic prophylaxis may prevent a small number of cases of infective endocarditis in patients receiving dental treatment. But again, we want to be very conservative. And there are risks of antibiotic-associated adverse events that may exceed the benefit, if any, of the antibiotic therapy. So maintenance of optimal oral health with daily biofilm removal, brushing and flossing properly, may reduce the incidence of infective endocarditis due to the bacteremias caused by the patient's daily activities. I've only had one patient in all my years where they told me their cardiologist told them not to use dental floss because of the bacteremia. They might bleed when they do it, and it was just, I had to do a double take. It's like, you're kidding. Well, if you're not flossing, you can guarantee you're going to bleed. But literature reviews found no evidence-based methods to decide exactly what procedures require prophylactic antibiotics. Other factors that really limit conducting controlled research for who needs it and who doesn't is that there really is a low incidence of infective endocarditis, and there are a wide variety of types of cardiac diseases, as well as a variety of invasive dental procedures. So the incidence when antibiotic premedication did not prevent infective endocarditis following dental invasive procedures, we really don't know. So there are 4 principles that we're going to discuss. One is only an extremely small number of cases with infective endocarditis might be prevented by antibiotic prophylaxis for dental procedures, even if the prophylactic therapy were 100% effective. Another one is infective endocarditis prophylaxis for dental procedures is recommended only for patients with underlying cardiac conditions associated with the highest risk of adverse outcomes from infective endocarditis. And for patients with these underlying cardiac conditions, prophylaxis is recommended. Again, we're talking about antibiotics before the treatment for all dental procedures that involve manipulations of the gingival tissue, peripheral region of the tooth, as well as perforation of the oral mucosa. And finally, prophylaxis is not recommended based solely on an increased lifetime risk acquisition of infective endocarditis. So, medical conditions right now that require antibiotic premedication. Okay, look at the box on 10-2 for the cardiac conditions, and 10-3 also lists some of the dental and dental hygiene procedures for which endocarditis is recommended. What they're finding is the patient is more at risk of acquiring immunity or to the antibiotic or resistance to the antibiotic, so it won't be effective for them, as well as an allergic reaction. Medical conditions requiring antibiotic premedication, prosthetic cardiac valve, previous endocarditis, congenital heart disease, and cardiac transplant recipients with cardiac valvular disease. Some of the dental and dental hygiene procedures that might require premedication: manipulation of the gingival tissue, the periapical region of the teeth, and perforation of the oral mucosa. Now, that does not mean an injection. One injection does not require premedication. Manipulation of gingival tissues. If you have a patient that requires premedication, you can do the EO-IO, the oral inspection. You can do possibly radiographs. You can chart the gingival margin and measure the mucogingival line, but that's about it. There's no manipulation of the tissue that might induce bleeding, and that includes toothbrush and flossing instructions. Procedures for in which premedication is not required: routine anesthetic injections, taking dental radiographs. Normally patients don't bleed during that. The placement of removable appliances, adjustments of orthodontic appliances, the placement of orthodontic brackets, the shedding of primary teeth. That's a natural phenomenon from the patient. And bleeding from the trauma to lips or the oral mucosa. So we have this ASA classification that we talked about in clinic, and with the completion of patient histories, an overall estimate of the medical risk of a patient can be made. So the American Society of Anesthesiologists, ASA, physical status classification was developed, and that describes 6 categories of physical status and provides examples of adaptations necessary for providing dental hygiene care for the patient in each category. So you've got an ASA 1. You've got an ASA 1, which is a patient without apparent systemic disease, and they're normally healthy. ASA 2 is with a patient that has a mild systemic disease, and that's controlled. Asthma, for example, is an ASA 2. Seasonal allergies are an ASA 2. So there's some gray area with that as well. I'm on blood pressure medication, and my blood pressure is 110/78. No, that's not my blood pressure, but that is a mild systemic disease, hypertension, but it's well controlled. ASA 3 is a patient with severe systemic disease that limits activity but is not incapacitating, or it's not controlled. So if I was on blood pressure medication but my blood pressure was 150/96, that would make me an ASA 3 category. I would refer that patient back to their physician. ASA 4 is a patient with incapacitating systemic disease that is a constant threat to life. As I said in lecture in class, that this oftentimes is the patient that you'll see that is waiting to get some sort of a transplant, and they need to make sure that their mouth is free of infection before they can go on to that surgery. And ASA 5 is the patient who has one foot in the grave. So you're going to review and update the medical history each and every appointment. So if you have a patient next semester that's all day, from 9 to 12 and then from 1 to 4, you are going to, at that second appointment for that same day, update that medical history. It's only going to take you a couple of minutes. Are there any changes from this morning? Have you taken any medication since we saw you? No, because sometimes they will take ibuprofen, they'll take a sinus pill, heaven only knows, but you just don't know. So you have to ask, and you'll take the vital signs again, and then you'll get the patient checked in. You don't have to go through the entire history again. But changes in the health status can have consideration with your care plan. So a lot of offices will have posted on the wall, please advise us of any changes in your medical history since your last visit, but it really is up to us to ask the patient, and it's up to us to have the patient sign a medical history update. Following a review of the previous recorded history, then you can direct questions to compare what's going on with them now. Have you been ill or hospitalized since the last time you were in? Have you seen your physician for any reason, even well checks, since you were last in? Have you had any laboratory tests done since you were in last? What is the list of current medications? Again, we're not asking, have your medications changed? We want to know what is the list of your current medications. We advise the patients to keep a list with them. I don't know, I take a blue one and a red one, and I think I take one for my blood, and this one's for my heart, and whatever. Patients need to be educated as far as why they need to know what medications they're taking if they can't remember them, and to keep a list with them of their current medications. And we're also looking for changes in oral soft tissues and teeth. So a person's health history or health is not static. Doesn't stay the same. Therefore, a health history must be updated when and how often. And of course, the correct answer is at each and every appointment. So this gets us into documentation. Document, document, document. We're going to date all records. All hard copy permanent records have to be handwritten in ink. Some will even go farther to say blue ink versus black ink. Blue ink cannot be photocopied as well as black ink. So some offices use blue as their standard color. But electronic patient records, which we use at Germanna as well as in Springfield, are what we're doing. And they must be stored in a secure server on a password-protected computer, right? Think about your OSHA training that you've had. All electronic charting documentation are signed electronically and saved in such a way that falsifications to patient records can't be made. So they also provide a specific line on a health history form for the signature of the patient. And the completed history for a minor is signed by the parent or guardian. The signature is also needed on the informed consent form. And we're going to go over all of those forms this semester. And for patients with special health problems that require pre-medication or some type of color-coded tabs on paper or pop-up alerts in the electronic records will notify the dental personnel to check the medical history. Now, for the privacy of the patient, we are not, for paper charts, we're not putting health alerts, pre-medication, allergic to, danger, danger on the outside of records anymore. The last office I was in before we went to paperless, we had color-coded dots, and I would tell the patient, I'm putting a red dot on your chart because this will tell us, because they're allergic to penicillin, for example, to just review your medical history before we proceed. The yellow dot tells everybody that you've got insurance. So I let everybody know what it is, but that's how we got around that. We used to have stickers that were fill in the blank that were on the outside, where we could write in HBP, high blood pressure, allergic to, that type of thing. Now that is no longer allowed. So we've got our progress notes that document regular updates, and on box 410 of this chapter, it gives you examples of what progress notes can look like. So documentation is key to everything we do. You will be at the computer a lot, and we luckily have templates that will guide you on what you need to fill in. So that is Chapter 10 of Wilkins.